start, and we're going to do talking a lot about hereditary cancers and genetic testings and all of that tonight. So why don't we start on the far end then with Greg, and then anybody else. You're all wired with a microphone there, so just hop right in. Question: how does genetic testing for hereditary cancers fit into your practice?
Well, it's a daily conversation in my particular practice as a cancer surgeon, particularly one with a great deal of focus in breast cancer. So these are conversations which are frequent, delicate, important, and have a certain time sensitivity to them, particularly for patients being diagnosed with breast cancer and now having their genetic risk assessment become a part of their surgical decision. So we know the criteria for when and why to test the patients, and we understand how to counsel them, and we do facilitate them getting their samples sent off quickly. In fact, my nurses, Casey and Stephanie, have really pioneered and taken over getting the pre-authorization for the insurance companies and helping these women. But the primary issue in my practice for the newly diagnosed breast cancer patient, which would be different from Tammy's circumstance, the primary issue for the breast cancer patient who now has breast cancer is to decide, is she a proper candidate for lumpectomy, which is the most common chosen surgery, or should she consider her genetic risk and possibly consider bilateral mastectomy, incorporating treatment and maximum prevention of new breast cancers. That's the main issue for the new breast cancer patient. Not all breast cancer patients, in fact most, do not need genetic testing or have an indication for it, but if they have an indication, that needs to get moving right away. For the patient who comes in, let's say in Tammy's circumstance, where they are either at risk or have a known mutation, they have more time on their hands. They do have some options, but I deal with those circumstances as well. That's a completely prophylactic discussion of complete prevention. I'm not treating anything. I'm working as a surgeon to prevent something.
Yeah. When it comes to seeing patients with cancer, genetics aren't the first thing we're generally thinking about. Most of us, I'm a medical oncologist, and we, surgery and radiation, the same thing. The patients come to us, we want to treat the cancer we see before us. So genetics is always sort of in the back of our minds. We want to make these people feel at ease about what's going on with their situation. We have excellent care now for all types of cancer. The surgery, the radiation, and the medical oncology has grown tremendously in the last several decades. So we're very confident that we can help people, and we want to deal with the cancer right away. But we always have to keep in the back of our mind that there's this, there are family members here, and they want to know about this. Their loved one has cancer, and they want to know, well, is there a problem that we might have as well? So we really have to be, as Greg was saying, quite sensitive to the person, not just jump in there and attack and treat this cancer, but really think about the background, what actually may have caused this cancer in the first place. And I think that tends to be underspoken about even when we're counseling our patients.
Okay. Another question. If a genetic test is done, the result is positive, what is the difference in the treatment for the patients? How effective is the treatment in saving the patient's life by preventing a future cancer? I know we talked a little bit about that already, but can you go into any kind of detail on any of that?
I think the numbers discussed when you introduced Tammy are pretty representative for BRCA1 mutation. So that's kind of the classic, and I don't know if it's the oldest, but certainly the most perhaps well known when we all think of genetic mutations affecting treatment decisions for breast cancer. That's kind of the classic one. And so patients with BRCA1 mutations generally have a huge risk of breast cancer, 85 roughly plus %. And the risk of ovarian cancer is about half of that, which is also huge. Most patients in that facing that decision if they have a mutation, their personal decision. As Ken was saying, we have to decide what are they going to do for their cancer first, and then we talk about their family and, their daughters, et cetera, and sisters. Usually they're going to decide to have a bilateral mastectomy. That's not, as Greg was saying, not the first or most popular or best choice for most women with breast cancer, but when you have a mutation, you've got an 85+% chance of having that mutation cause a future breast cancer. Most women choose a bilateral mastectomy. And it doesn't make the risk zero after that, but it brings it down to single digits pretty low. And ovarian cancer, as we all know, is generally very deadly. Not that breast cancer isn't, but it's much more curable in general. But ovarian cancer, most women will have their ovaries removed, so have a bilateral oophorectomy in that case. So it really impacts those decisions surgically immediately for Greg and his colleagues. And I don't know what else beyond that you would say, Greg.
The only thing I would say is it even drills down to what mutation you have, because the BRCA1 patients develop their ovarian cancer at a different age point on average than the BRCA2. Taking the ovaries out does have a significant impact, more so the younger you are. So if you're 35 and you lose your ovaries, menopause at that age is very disconcerting, can be a tremendous change in the quality of the life. And again, as physicians, we're trying to provide care that provides quantity and quality. And to just knee-jerk get a BRCA result and say, yes, you need to go get your fallopian tubes and ovaries out may not be the wisest. There are even people looking into potentially, now this is a bit avant-garde, just taking the fallopian tubes and preserving the ovaries, because the vast majority of these cancers develop in the distal aspect of the fallopian tube, out near what's called the fimbria. And that's why we see ovarian cancer disseminated through the abdomen. It literally shoots out of the fallopian tube. So there might be options for a staged approach where the tubes are taken out and then you come back later and take out the ovaries. That's not traditionally the way it's done. Traditionally it's fallopian tubes and ovaries. But this is an important aspect, but has to be delicately balanced with how old you are, what the risk is. We do not have good screening tests for ovarian cancer. The other thing that has entered the picture is MRI of the breast. And because most breast cancers are curable if found at an early stage, I have found an increasing number of patients that are BRCA positive not utilizing that information to go right to mastectomy in their younger years, but rather to get on a more aggressive surveillance schedule with annual MRI and delaying, if you will, the prophylactic mastectomy conversation. So there are a range of 3 or 4 options available to the patient, but they certainly have decisions to make that are important.
I see Tammy over here nodding her head at everything that y'all are saying. Mm-hmm. She understands perfectly what they're referring to, because you've heard this before, haven't you, Tammy?
I have. I've heard this before. Both of my older sisters going through their cancers and the decisions that they had to make with their surgeries, and then myself being positive and taking proactive preventative measures, the surveillance as the physicians referenced, and then when appropriate with me, making that decision to have prophylactic surgeries. And then with my daughter, she's so young, she's BRCA1 positive, so it's important that she has her surveillance, her MRIs, and she's watched, but right, it's not a knee-jerk reaction to go into surgery right away. So there's other options out there.
Ken, you look like you're about to hop in there.
Well, the complexities of the genetics of cancer have really come into the fore in these last 10 years. We've discovered so many new genes. The BRCA is certainly what we're talking about here. That's the most important and the most common. But there's many more that have been discovered, and it's important when I'm talking with patients that I tell them it's no doubt that the cancer itself has a genetic problem. The reason there's cancer is because there's a genetic defect in a normal cell. That's how it becomes cancer. but that doesn't mean there's something wrong with your genes that led to that. So some people think that I got cancer because I had something wrong with my own genes within my cells, but that's not true. Most cancers are due to genetic defects, but those are more sporadic or spontaneous genetic abnormalities. So fortunately, when we're talking about, we're doing genetic counseling for patients, it's really only going to amount to about 5%, at most 10% of our patients who may have an underlying genetic abnormality. So the perspective when we're talking about oncology patients in general is, the families are probably, just by sitting there, you can almost be reassured that you're probably not going to have a genetic abnormality until we start taking more detailed history and then getting the strong family histories. Then we can start saying, yes, the percentage chance that you have a genetic defect that led to this cancer is getting higher and higher. But it really should be said that most cancers are sporadic and spontaneous, no fault of anyone, no fault of what you ate, no fault of, in fact, most aren't even related to what we eat or drink or smoke. Most cancers are actually sporadic.
I know when you get the diagnosis, you go into a panic, not only yourself, but your family members as well. So Heather, that's where your job comes in as the Director of Education with Hope Abounds, making sure that the proper information is disseminated to those and make sure they understand that, because many times, in a lot of cases, I would say they're probably not thinking exactly straight on diagnosis. They've got to get over that initial impact, cancer.
Sure, absolutely. And, as Dr. Fink said, it is one of those things that you have to not only look at that patient, but also their family history. So there are some red flags that Dr. Bebb referenced. So young cancers, so 50 and under is young, or 60 and under with certain pathology. If it's breast cancer, it'd be a triple negative breast cancer. If you're talking about colon cancer, it's certain histological features in that colon tumor. So that adds an extra decade. So 60 is young. Or rare cancers. So those ovarian cancers, it doesn't matter if they're 99, that patient would be eligible for testing. So just because that's such a rare cancer. Or multiple cancers in the family. And there were some family history forms that were given, and if you can utilize a written tool within your practices, that's a better way to really gather that family history to see if a patient's appropriate for testing, because there might be a 65-year-old breast cancer patient that's passed that, even if they're triple negative at that point with pathology, but if you're not asking about family history, you don't know that her grandmother had cancer, breast cancer, and her sister had breast cancer. So she would qualify for genetic testing because that's multiple cancers in the family. So it's just really important to know the potential red flags of the patients you're seeing, or if you are a patient, to be able to know that for yourself to prevent a secondary cancer or for future generations to develop cancer as well.
And Sarah, after the doctors come in and they do what they have to do with the news and procedures, many times I'm sure a lot of the patients have turned to you, the nurses, to try to get some comfort and maybe a different kind of understanding straight from the nursing standpoint.
We have a really nice supportive staff at our office. And to go back to what Heather said, a lot of what I do is actually in the fact gathering when I'm doing the annuals and physicals and making sure that we have the correct information to see if they qualify for testing to prevent rather than wait until diagnosis. And it's interesting that I've at times had a woman I've seen maybe once or twice and ask, has anything changed in the past year? And they say no. Say, oh wait, my dad had cancer in October. And I'm thinking, yeah, that's a big deal. So it's a matter of getting information and knowing which patients are the right ones or the appropriate ones to test and help protect their families.
Just out of curiosity, does everybody can hear okay, I guess, what they're talking about? Has anybody got a situation that they're facing, what we're talking about right now? Okay. Over in the back? Okay, in the far back, okay. So if you've got questions or that you need answered specifically in your situation, please jot it down on the card and we'll get it to these doctors and the medical staff here. in those and get your questions answered. We'll take that question one step further. If the result is negative, does medical management change for the patient?
Sure. So, yeah, for medical management, so our treatments for this cancer, there are not a lot of distinctions. So if a person has a BRCA1 related breast cancer versus not, the treatment's not different. We actually still look at the malignancy itself, look at the features, the hormone receptors, and so on. And we know our therapies are getting really good. We have targeted therapies now that are not toxic, directed towards the receptors that may be on the cancer cells and that type of thing. But whether or not the constitutional gene led to that cancer or not doesn't change the therapy. We have what it is with the BRCA gene is it's a tumor suppressor gene. It's actually a gene that's designed to repair the DNA. So what happens is breast cells, as they are getting older, they tend to DNA is being reproduced as the cells duplicate and errors occur. Normally, the BRCA gene would come in and repair that error. When you have a defect in the BRCA gene, that error is not repaired and the cell becomes defective, or the gene becomes defective. And most of the tumor gene, most of the genes that lead to cancer are tumor suppressor genes, have that same sort of function we call repair genes. What we have found is that there may be some drugs that can actually target that particular mechanism. If these cells have a defect in the ability to repair DNA, we have some drugs that can actually induce DNA breakage that the cell cannot fix. Therefore, it will be destroyed by the cancer cells, so by the chemotherapy. So we're actually combining some new drugs that will enhance lack of correction of a DNA break. And so that might make a difference in some of our patients. As yet, that's not been become our usual practice, but we're making important strides in that direction.
Probably a lot of women, folks need testing, but they run into an obstacle called the insurance company. So does the insurance company generally cover this kind of genetic testing and the expense for the patient?
Want to take that?
I probably have the most interface on that score. It varies insurance company to insurance company, and each insurance company has picked particular genetic testing companies that they like. They have different hurdles, and this has really become frustrating, I must say, particularly with one or two of the carriers, because I've got a newly diagnosed breast cancer patient and the genetic result will impact their surgical decision. But some of the carriers won't authorize payment until review, and that review will be 3 or 4 weeks. And then they want us to send it off to particular companies through particular labs and wait another 3 or 4 weeks. Well, no patient is going to wait 8 weeks for their surgery. Now, it's less of an issue if the patient's going to be having chemotherapy first. I have time to go through all the hurdles that are there. Some of the hurdles, I think, are very unfortunate, and we're trying to work those out state by state, and it is frustrating. And some of those hurdles are fairly new over the past year or two. We had very little difficulty until the past year or two. So that's what I would say about the insurance companies. Now let me say, too, in defense of the insurance companies and in terms of genetic awareness, for all of the difficulties that we may have with assurance pre-authorizations and getting things done in a timely manner to facilitate a proper breast cancer surgery, for as much difficulty as there is, I think the biggest hurdle to having genetic testing done is still really in our lap as the doctors. I think very few patients who have prostate cancer with a Gleason score of 7 or greater are getting tested, and even though there are indications for that. I think very few patients with fallopian tube or ovarian cancer are getting tested. Very much underutilized test. And I think a significant number of patients with breast cancer that are appropriate candidates are being undertested, and colon cancer. So I still think the biggest hurdle lies on the physician side, because as Ken said earlier, as Pat said, may have indicated, I can't remember which of the two, we tend to focus on the cancer, but we really do have to widen our scope a little bit and be thinking about this genetic parameter, because it really is now no longer just an added detail. This is a therapeutic intervention detail that is critically important to how we set up the patient's care plan.
I mean, the impact is most on the surgical decision making, and again, if you've got a difficulty, getting this test, people will just default to a usual type of practice. But it's getting more and more used to this test being available, and then realizing what effects it's going to make on the decisions. As I said, it may start to affect some of the medical therapies down the line, but it's not there yet. So it's really not in the forefront of even the doctor's minds, because it's not going to affect at least from the medical standpoint, what we are going to do. But from the surgical standpoint, I think it's becoming much, more and more in the forefront of their minds.
Do you have anything?
I would say, on a related note, there are very few, just sticking with breast cancer, and I certainly don't want to talk about breast cancer all 2 hours. We should probably talk about other things, but patients with breast cancer, there are very few patients who need mastectomies, and in this country, for various reasons, women are having too many mastectomies, particularly prophylactic mastectomies due to lack of education, due to surgeon bias, due to other factors. One of the very few clear indications to consider bilateral mastectomy is having a BRCA mutation. There are very few other ones. A really big tumor in a small breast. Obviously, patient preference. If a patient wants a bilateral mastectomy, that's no problem. But I think a big problem as far as breast cancer treatment in the country is over-treatment with bilateral mastectomies. And it's been reported in medical literature, and it's something that we're trying to get education-wise to patients and general doctors as well. So that is a huge impact. If a patient comes in, most patients won't have a genetic mutation, so they need to take that way back. That option of having both their breasts removed really is not necessary, and they need to really understand that, and their families need to understand that. So that's a big, critical piece of information, I think.
Okay, to follow then on what Greg said, if we have already, you have to go through the insurance situation, as you mentioned, as being pretty frustrating, and then making sure the doctors are up to date with all of what's taking place with genetic testing. If the physicians are not doing that right now in their particular practice, how does a physician get started in something like that?
Well, I think that's the purpose of this, right? I suspect there are some physicians at the other hospitals that are watching and linking in. I think this makes its way out through our societies, our annual CME meetings, tumor boards. Pat and I sit on a breast cancer tumor board monthly. And, I think it's slow, steady education.
Sure.
Patient reception. I'll often have patients who are appropriate to be tested, and for whatever reason they'll choose not to. And you have, as a provider, you have to dial it back and not push them, because they have to come to it in their own terms in their time. But
the fear factor, I think, is still something that we have. Well, if we can bring it down a little bit, but the patients have such fear. So a woman comes with a breast cancer, her first fear is that she'll have not only this breast cancer, but a second breast cancer. There are misconceptions that one breast cancer will spread to the other side. So they ask for a double mastectomy, which is not true. But they may have an inherent fear that even if I have a genetic mutation or not, I got this first breast cancer, I'm going to be at risk at some point in my life for a second breast cancer. Let me go ahead and have that removed. And I think that's where that double mastectomy is coming from. It's just the fear factor. Cancer is always going to have that effect on our patients. And we're there to educate, and we can tell them, we could probably allay that fear by saying, we've done the test, your BRCA test is negative, and now we have an extended risk profile. We have 25 other genes we've tested for, and they're all negative as well. Your cancer was sporadic. You're probably not at that much more of an increased risk for a second cancer. Although once you've had one breast cancer, you're always going to be at some increased risk for a second breast cancer, but not to the same degree as if you had a genetic mutation.
Sarah, we have a question for you. Could you address the QOL issues regarding sexuality long-term with patients who have had BSO or total hysterectomies?
There may be some disagreement for women who have tested positive or who have had breast cancer and ended up needing to have traditional hormone therapy replacement. There are other options. There are products that are not hormonal. However, I do offer my ladies vaginal estrogen cream, and I keep going to the oncologist. I don't know how y'all feel about it. So that one of the gentlemen from Duke said we have done a grave disservice to our women, telling them that they can't use at least vaginal Premarin. And for those of you who may have gone through menopause or had that experience, it's very, truly, dramatically life-altering and changing, and we can help them with that. Another problem there is some of the women just don't feel that they can even consider the possibility of using a traditional estrogen cream because they're fearful it's going to trigger something else. And the majority of women don't absorb it systemically. And yet I will have some people say, no, I had breast tenderness after that, I'm just not going to do it, and that's fine. We have other options.
And Gray, this one over to you. This person also heard at a symposium that a provider who tests positive may have to pay more for life insurance. I know we talked about health insurance before, but is there any kind of legislation that you're aware of, anyone's aware of, to address that situation?
I'm going to answer that. So GINA, Genetic Information Non-Discrimination Act, is out there and available. It's been around for over a decade, where patients can't be discriminated against for health insurance or employment. Life insurance is a very different thing, but if you've personally been diagnosed with cancer or have a strong family history of cancer, your life insurance rates are going to be substantially elevated anyways. I've never personally had cancer, but I have very strong family history on both my maternal and paternal side of my family, and so my life insurance is at an increased rate. But Tammy, you might be able to give your...
If I could weigh in on that as well. So before I went for testing, genetic testing, I made sure I had my life insurance, and as Heather alluded to, I had a strong family history, 3 older sisters with in remission from breast cancer. So the life insurance takes that into consideration, and my premiums are probably a little higher. And then when I found out that I was BRCA1 positive, the premium stayed the same. However, as I went through my surveillance and then my prophylactic surgeries and my risk went down, my premiums actually went down. So.
That's good. That's good. Okay, a 45-year-old female, diagnosed stage 1 breast cancer at age 40, mastectomy and chemo, negative for BRCA1/2, diagnosed stage D, I think it is, colon cancer at 45. Mother died, breast cancer at age 50. Maternal grandfather died, pancreatic cancer, age 65. Maternal aunt died at age 57, endometrial cancer. The question is, test for Lynch syndrome?
Absolutely. No question. I think that's one of the most, everybody immediately gravitates magnetically to BRCA1 and BRCA2. But there are other genes very much linked into breast cancer, including the Lynch gene, the PALB2 gene, the CHEK2 gene, the PTEN gene, the TP53 gene. So there are other genes out there. The BRCA1 and 2 is not the only set of genes to check. And this family, particularly with the endometrial carcinoma, would be a Lynch family syndrome to check.
Let's see. Could anyone share your experience on how doing a genetic test for a patient change his or her patient care as well as for the family?
Gray probably has the most experience.
I can do that.
Yeah, you've got a lot of
I'll give you one just this week. I saw a patient with a breast cancer diagnosed, not with any of the criteria that you would do genetic testing. She was 63 years old, so she didn't meet the under 60 for triple negative or under 50 for ER positive. So 63, new breast cancer patient. If that's all I did was look at her mammogram or ultrasound, do her physical, develop a treatment plan, and that's all I thought about, we'd be right to lumpectomy, radiation discussion, and hormonal therapy usually. Sitting in the corner of the room was her sister. Her sister said, well, I had breast cancer as well. And as I was taking the history, I said, well, how old were you when you were diagnosed? 40. I said, well, have you ever had genetic testing? No. Has anybody talked to you about genetic testing? No. And she had been treated and followed for 20 years at a tertiary care major research university, including this past year. So she was my patient the following day because she wanted to get genetic testing. Now, because of the insurance hurdle, this particular lady has the insurance that is a problem, so her sister now is going to be 8 weeks to get the result, and then my patient would be another 8 weeks, so we'd be 16 weeks out. Certain insurance companies are less of an issue with that, and we can get the result back in 3 or 4 weeks, but there was a real live circumstance that we had just this week.
I'll give the opposite end of the spectrum. So, a young lady who's a friend and former colleague who is in her mid-30s, who has an aggressive triple-negative breast cancer. And for the folks in the audience, we talk about triple-negative, meaning we look at a couple markers on the breast cancer cells, and so if they don't have estrogen receptors, progesterone receptors, and this other two called HER2, if they're all negative, they're called triple-negative, which tends to be a more aggressive, earlier spread to other sites, more lethal breast cancer. So this young lady is in her 30s. She's got this, lots of risk for having a BRCA mutation. They're pretty well linked. She gets her testing and it's negative. She's thrilled because she doesn't necessarily have to have a mastectomy. She can have breast conservation with surgery and a lumpectomy and radiation, keep her breast. She's a young lady. She's still going to have chemo because of the aggressive nature of her cancer, but she can keep her breast. And so she was thrilled about that. So it's kind of, the testing does impact treatment both ways.
My patient was, she was in her 30s when she had her breast cancer, and this was a military family. They were moving around a lot. Unfortunately, the military did go ahead and do the genetic testing on her, and she was positive. Now, fortunately, they were a big family. They had about 4 or 5 kids, and she went ahead and had the bilateral mastectomy and oophorectomy. I was seeing them in follow-up. They felt very confident about themselves, very confident about their future, realizing that she had this positive test and that their children wouldn't need to be tested as well. I felt very secure that this test was available to them and for their children, and they were able to go through life with that kind of confidence. So I think it made a big difference.
Talking about a father's cancer, grandfather's cancer, I think, a few minutes ago with pancreatic cancer. If the father of 2 adult daughters has had cancer, prostate cancer, should the daughters be tested, especially since the father was adopted and has no prior family medical history?
Well,
That's the only cancer is prostate. At what age?
It doesn't say.
So the answer to that comes down not to the age, but to the Gleason score. This is something the pathologist gives. So if the Gleason score is 7, he should be tested, not the daughters. So the focus of genetic testing is to test the most likely person to be positive, and the word we use for that is proband. So if you hear that word, that's the person you want to focus on. Just like for the patient I just discussed, I didn't test the patient, I was going to test the sister who was 40 at the time of diagnosis. And the National Comprehensive Cancer Network guidelines have addressed this issue of adopted people, and I would encourage medical providers out there to be very familiar with those guidelines. There are special carve-outs for these people, understanding that we're working with limited data, and if you have limited data, you might be more likely to genetically test based on fewer pedigree, fewer family events because you just don't have the information. And so you might be more likely to test in those circumstances. So you have to be very familiar with guidelines that have been set out, and I particularly find the National Comprehensive Cancer Network guidelines to be most helpful. The American Cancer Society has their own guidelines. The American Society of Clinical Oncology has guidelines. All of these are helpful, but the NCCN is sort of the standard bearer.
Triple negative is what this person is asking about. Many people hear negative, think it's a good thing. Can you explain triple negative?
So that's a little bit the case I was just discussing, where it has breast cancer doesn't have these 3 receptors, which makes it triple negative, which is not a positive. It truly is negative for the patient, in that it's more aggressive. It can spread. It's classically can spread to places like the brain earlier. It's treated a little bit more aggressively. Most patients with triple negative cancer get chemotherapy. Most of those patients actually benefit from radiation more so. So lumpectomy and radiation tends to be better for them than a mastectomy, which is a little bit counterintuitive. But for whatever reason, there's pretty good data for that to be the case. But basically, it's an aggressive form of breast cancer that happens a little more often in younger patients, and it can spread to distant sites, classically the brain and other sites, earlier and more frequently than more positive or favorable breast cancer that has estrogen receptors and progesterone receptors positive.
We're understanding the biology of breast cancer a lot more, and we've started to put them into categories. You know, we used to say just ductal cancer or lobular cancer, but now we're actually looking at we're not even talking about how it looks under the microscope, but rather how the receptors come out. We've actually got 4 or 5 different categories now. We've got HER2 positive breast cancer, we've got triple negative breast cancer, and then of the hormone receptor positives, there's a type called luminal A and luminal B, one being a little bit more aggressive than the other. And this is really making a difference as far as the type of treatment. And even the understanding of how it came to be this way. We're not really, again, the genetics as to why did this cancer cell why did this person's cancer decide to be triple negative as opposed to being a luminal A or a luminal B. And we're becoming more and more aware of that. And it all comes down to the genetic aberrations within these cancer cells. So not only do we know about the BRCA gene that can lead to the cancer, but we're actually learning more about the genetics of cancer itself and what are these defects that we can find. So we can study a person's normal cells and say you may or may not have a genetic defect, but then we can actually study the cancer cell itself and say we can actually do a molecular profile, do special testing and say these are the molecular defects within your cancer, and our therapies are becoming more directed in that way. So we've come a long way.
Bob, I might weigh in on what we mean by triple negative and explain it maybe more simple terms. If you could imagine a cell or a circle, and on that circle you have little buttons. That's what we're talking about. So you have an estrogen receptor, where if body estrogen hits that receptor, bad things happen. The second one is a progesterone receptor, and if progesterone hits that receptor, bad things happen. And the third one is a HER2 receptor, which has a different mechanism unrelated to estrogen and progesterone. So these 3 things that sit like little buttons on the circle are things we can manipulate. So we like having these 3 receptors because we can do things. The estrogen receptor tumors are very frequently well treated without chemotherapy. In fact, usually 85% of the time properly treated without chemotherapy. The HER2 receptor, that button, used to be a bad signal. We did not like that. It's now become maybe okay. Now those patients do get chemotherapy, but they also get immunotherapy. And we have, as Ken has alluded, what we call targeted, something that hits it. And there are now 3 or 4 drugs out that are very effective against the HER2. So this HER2 receptor, which used to be one that we didn't want to see, now almost becomes one that we're saying, oh, good, you have that. There's things we can do and manipulate.
And with triple negative, we don't have one of those receptors to work with, so it's actually an unfortunate situation where we don't have a targeted therapy. But we are finding out that there may be some other avenues specifically for triple negative, and that's where we're talking about some of the genetic testing or some of the genes that might deal with a correction of the genetic defects. And if we have some drugs that can go after that, that may actually enhance the effects of chemotherapy, which is really all we're giving now for people with triple negative breast cancer.
Looked over here, Tammy, did you have any?
Oh, no, I
Okay. Just looking
You're
around.
eager, thank
Hey, we're real informal in here. If you get a little thirsty, there's a pile of water back on the table back over there. So just get up and go and grab a bottle. You're not going to interrupt anything. How often do you test family members that do not yet have cancer if a positive result is found in your patient?
Very often.
So we're talking about testing the family member of someone with a mutation?
Yes. How often do you test family members that do not yet have cancer if a positive result is found in your patient?
I think that's one of the, when we're counseling our patients, usually the family is there, and they want to know if, if this affected family member has the gene or not. They're all worried, of course, about their family member, but they also have some worry about themselves, and that's I think the design of genetic testing is to find out if the proband has the gene, then certainly start testing the family members. Anyone who's a direct family member, a first degree relative, would be appropriate person to check. At what age do you start checking? That's maybe another question. For example, the patient I discussed probably don't want to check the children too early, but perhaps as they get closer to the age where the impact of that gene is more important, about age 18 or so.
How often do you discuss genetic testing with your patients before and after testing?
I think that's part and parcel of the test. The patient's not going to submit to it unless you've had a conversation with them. And some of the guidelines recommend that you actually have them sign an informed consent before you send it off. I would say that's a bit optional. You can include that in your medical record dictation. Certainly after you get the test, that's part of the conversation. So I don't think it would be reasonable not to have a conversation before and after.
And which provider and or specialist in the community has the responsibility to provide this risk assessment?
There was a time where we only allowed the geneticists, access to this test. A lot of us didn't feel we were capable of really dealing. First of all, it takes a lot of time. There's a lot of heavy counseling. Or family members want to know. You have to know the details, and we're not geneticists. We're oncologists, and we know how to treat cancers, but not necessarily know all about the genetics. Time has gone on, and we've become much more savvy and more aware of it. So,
All right. Biggest hurdle, still healthcare provider. Grade our area on genetic testing. Our family practitioners involved with testing or conducting the issues. Is it on the radar to improve the hurdle? All healthcare on board, a lot of different questions here. Why not, if not, in the future, as far as genetic testing, where we're going from here?
It's part of taking care of people. You have to get the information, and therefore you should be screening everyone when you see them. We have a form that we use when we have new patients that are coming to us. We're now mailing the form to them so they can have time to think about it and bring it in. And it does take time to sit there. I have patients all the time who call family members to make sure that they're getting accurate information. I had a little girl yesterday who thought her aunt had breast cancer. No, she didn't have breast cancer. She called her mom. Her mom had ovarian cancer at 42. Child didn't know it. I thought, well, that's interesting. And this kid's 28 and never knew it. So you have to ask the right questions and pick their brains, and if they can't remember, let them come back. But I tell my patients they can always call and we can update their record, their family history. And they do that.
It's very time consuming. The primary doctors aren't going to really have the time. They're busy taking care of a lot of primary things. Even the oncologists, as I said, just don't really have the time. We're really focused in on just taking care of the cancer itself. But I think it's becoming much more embedded now in our thought process as we're counseling patients. The family members around, people are asking good questions too. I think as the community becomes more aware of it, they're asking for things. I sometimes tell patients, if you really don't ask for something, you're probably not going to get it. So yes, it's our responsibility to talk about this, and yet it's the conversation I think that's going on between us, the cancer physicians as well, and the patients and the family members.
Ready?
Well, I think risk assessment on a number of different things is a heavy weight for Sarah, the primary care person. She's got cardiac risk to discuss, she's got cholesterol risk to discuss, she's got genetic history, but I think the primary goal of the primary care doctor is to establish an excellent history and physical exam. For all of our fancy testing, genetics, CAT scans, MRIs, still the doctor speaking to the patient is going to solve most of the problems. And so when we go through, we take a history of their present illness, the past medical history, what their allergies are, what their medications are, what their social history is. Do they smoke, drink, use illicit drugs? What's your family history? And I think we've just skipped over the family history a little quickly. I think the real conversation here is we're just expanding that. We're saying, no, let's pause there and just tune our ears to complete that as comprehensively as we can. And I do think we're getting to understand this better. I think in our era, when we went through medical school, we were not well taught about nutrition. I think that's been the rise of many alternative healthcare options to begin having a conversation about nutritional options, et cetera. We weren't well taught in that. And I personally wasn't really well taught in genetics. It was just not on the radar screen. But that's why we have continuing medical education events like this. We're trying to bring this up to the surface so that it is part of the conversation.
You have to be comfortable with asking the questions, and then what are you going to do with the information? That kept me from offering it for probably a year and a half until I joined the group that I'm with now. And bless your heart, I don't do primary care anymore, but my brain still works that way. And so as I became more and more familiar with what was available and what made people meet criteria for the testing, things became a lot easier. It's not necessarily quicker, but sometimes you can figure how to direct the questions more appropriately based on your patient's response.
You know, when you go to the doctor now and your primary care physician, and I have a great primary care physician, that we have a really good relationship, but every time he comes in, he's panting, he's out of breath, his tie is down around his neck, because he doesn't have a lot of time to spend, not like he used to. That's the economics of it today, as the business development has changed in medical. But he's in, how you feeling? Let me check your heart and your lungs. Got your flu shot? See you in about 6 months. Never anything. He doesn't have time. You know, I mean, as Greg said, do they have to stop back? Is it time for them to perhaps slow down a little bit and ask a little bit more about family history if they don't have a complete record of your family history, and maybe back up and start from beginning again and delve a little bit more into the history and genetics?
Yeah, the direction the way things are going is with the electronic medical record. You know, we're very busy. That's taking up a lot of our time now, and because of that, we're having less time with our patients. That's why we tend to be huffy and puffy with our patients, because we have to get back to that electronic medical record and start documenting. Which is what that's doing is that's forcing us to become much more specialized, and we tend to stay very focused on just what we can accomplish in those few minutes. Trying to broaden our responsibilities by saying, okay, now become the geneticist as well, becomes more difficult. What I think we have to do is, like I say, with the education, when families are coming in, when they're talking about cancer, they're thinking about family history. I mean, with a primary doctor, maybe not so much, but they're here seeing us as a cancer patient. They're worried about family. So the conversation tends to go to that. The family members are sitting there, they're wondering if they're going to possibly have this cancer that their relative is having. So the conversation does come up. So I think as we're speaking with our patients directly about this, in the oncology clinic, I think that's where the information is going to be elicited, and that's where the testing is going to take place.
And you know, the reality of it is that the doctors can't do everything. And that's why the amazing staff that they have around them to ask some of these questions. So the medical assistants and the nurses that are passionate about it and are asking all of these meaningful use questions that Dr. Bev alluded to. Do you smoke? Do you drink? How often? You know, there are a million questions to ask, but this is something to dive into, because in a perfect world, we would try to prevent cancers for future generations or catch it quicker. And the world isn't perfect, but the more we can do things like this to do education, and not just for physicians, but for their staff, it's so important, because one person could hear one thing that could change that entire patient's outcome. So that's why, you know, the nurses and the medical assistants understanding the, you know, who's important, who's not, the red flags, when to test, why to test, and make sure it's all written, because Epic and some of these systems are amazing because there is information gathered, but when they come in every year, if they're a survivor or for their annual, that needs to be updated. And the more that we can put information in these systems and gather and collect, the better picture that you have. And, you know, within healthcare systems, maybe it's not the primary care provider, but maybe the primary care provider will get some of those pieces of the puzzle. And when they go on to whomever, you know, their OBGYN or their surgeon, they'll gather other pieces that'll put that puzzle together, and that'll be the person that'll have the discussion.
Bob, I think you're hitting on a very important issue, and I think I'm concerned that with the pressure of HIPAA and Obamacare and the regulatory aspects of medicine, what's happening is exactly what was predicted. The patient and the doctor would get uncoupled. You would not have that face-to-face conversation. You would not have that detailed get to know you. You don't see the same doctor every time. Half the time you see some other provider in the office. And so blooming out of this is a competitive option in healthcare where the doctor doesn't run in and out, and that competitive option is called concierge medicine. And I'll give you a brief intro to that. Southport now has a completely filled concierge doctor. Wilmington has their first concierge doctor. The average primary care doctor has 3,000 to 5,000 patients in his practice. The average concierge doctor has 300 to 500. And the way they can make it work economically is they charge an annual fee of $1,200 to $1,500. But if you run the math on it, usually you're saving money because that doctor knows you, you trust him. The average visit is 30 to 60 minutes. He spent a great deal of time. I'll give you a classic example. A patient comes in and he spits this sentence out. I've got the worst headache of my life. What's he get? CAT scan. Boom. Why? Because it's been established in malpractice issues. And so he's trying to defend his future ability to provide for his patients and his family's workforce, so it's a CAT scan. But the doctor who has a half hour to an hour and his patient knows him says, look, this is the standard of care to go get a CAT scan, but I think in talking to you, your mother just died, you haven't been exercising the way you usually do, I notice your blood pressure is up 12 points, I think this is a stress headache. Why don't we have you come back this afternoon, I'll redo your neurologic exam, etc. Nobody has time for that today. But the concierge doctor does. It's same day visit, it's 30 to 60 minutes, typically a much more thorough physical, and back to what we would have expected in the yesteryear. And I think that you see that blooming out and actually saving money by not getting a CAT scan and MRI and a million different things.
We want to be good doctors. I mean, we all want to spend that time with our patients, but like you say, there are a lot of stresses keeping us away from it, and a lot of it is financial. But as good doctors and as well-trained oncologists, we tend to spend that time with our patients. And I think maybe the primary doctors can look to us, you know, for this kind of testing when they just don't have the time.
You're under a lot of pressure when patients come in. You have other patients to see you as well. Other things you have to do. You have to have a fine balance there, I guess, Pat. When you're talking with somebody at these life and death issues.
Yeah, I mean, I wouldn't want, I have a tremendous amount of respect for the primary care docs. I wouldn't want to be a primary care doc. I'm glad I didn't choose it, particularly now with the changes in healthcare. You know, and I'm a subspecialist, so it's a radiation oncology. You know, you got cancer, and then you got radiation oncology is such a subspecialty. And then we have subspecialties within cancer. You know, I'm more of an expert in head, neck, and a few other subspecialties. But we are fortunate that we can, when we have to, spend the time. We, in radiation oncology, we're not the ones doing most of the genetic talks because Greg and Ken and have most of the patients, you know, breast cancer patients have usually had to talk with the surgeons already. So we're kind of the reinforcer. Oh, you remember what they said? Yeah, let's think about that test. But we're not as burdened as some of the other docs are, so we can spend the time really focused on the cancer and the treatment options, and that's kind of where we kind of, so we're fortunate. Not that we're not busy, we're plenty busy. There's no shortage of cancer in southeastern North Carolina, but we're fortunate in that regard.
Did you find this an issue, Tammy, when on your journey as well? Time spent and understanding and everything?
Well, it's interesting to hear all the conversation. Unfortunately, I was tested because there was cancer in my family. And it was my 3 older sisters in their 30s, 31, 33, and 39. And I always say that was very devastating to watch that. And I wish my sisters had the opportunity that I had. I'm unaffected. I have not had cancer. When they were diagnosed with cancer, they didn't have control of their treatment plan. They met with their doctors and they discussed their surgery options and chemotherapy, radiation. I had the privilege of taking my time, of mapping out my treatment plan, of meeting with my surgeons, meeting with my gynecologist and saying, getting their opinions, their professional opinions on what my treatment plan could be. And that was so nice to have that, to go through the surveillance and medication options, and then, like I said, when appropriate was, for me, prophylactic surgeries. It would be nice to catch unaffected patients in the office. And I know doctors don't have time, but as Dr. Bebb alluded to, taking a pause with that family cancer history and maybe widening that scope and asking a few extra questions, you may catch some people who are unaffected, who have this family history, like myself, have them tested, find out that there may be a genetic mutation with that patient, and hopefully prevent cancer. So with my daughter, when she was tested at 21, and some people say that's young, remember I had a sister who was diagnosed at age 31, so we tested 10 years prior. I didn't want her tested at 18. She went to college. I wanted her to wait a few years until she was ready, and she felt at 21 she was ready to know. But it was important for me as a mom. I know I have this gene mutation, and there was a 50-50 chance that she could inherit this, to protect her and make sure that she was okay. And by that, it was genetic testing. And when she was positive, I knew that she had to be watched and under surveillance. So, I know a lot of patients are caught with the breast surgeon and the oncologist, but if we can catch that unaffected patient in the OBGYN office or the GI's office, or even the primary care, that would be really ideal.
I was wondering how you handle all this mentally as well as physically, knowing that you have this mutation and all of this information, family members in the past, children,
Right.
in the same situation. Physically, you're covering, how do you handle this mentally?
Well, I have my 3 older sisters who are probably the most beautiful, courageous, brave women that I know. So they've helped to guide us. We have strong faith. Well, just a very positive, outlook on life. I'm very fortunate. My sisters are very fortunate. One was diagnosed with breast cancer in 1994, and she's still in remission. The other 2 were triple negative. They're still in remission. So, you know, great things have come from knowing that we have this genetic mutation. My sisters were able to prevent a secondary cancer. And then, like I said, with myself and my younger sister and my daughter, we have an outlook on life that's just so positive because we're able to prevent cancer. And some people ask, with my daughter mentally being so young and finding out that she was BRCA positive, and is she anxious, and you know, we get those types of questions. Yeah, when she goes in for her MRI, there's some anxiousness there. And I won't lie to you, when she went for her testing, there was that anxiousness there. And when we received the result back, it wasn't what I really wanted, but at least we know. But I'd rather have anxious over devastating of a diagnosis of cancer for my daughter. So.
I think the information that patients get from this is empowering, and I think it actually reduces the fear. There's usually, a lot of people say they don't want the test, and they probably have more fear than those who actually get the test, whether the test comes back positive or negative. So once you've come back positive, I mean, her daughter now has this information. She knows with confidence that she's going to get her MRI, which she otherwise wouldn't be getting if she didn't have that test done. So I think it actually reduces the fear, and I think this information is empowering. And like I said, I think it's real important when the patients start asking these questions. I'm sure this testing wouldn't have been done without the patients actually asking for this test and asking their primary doctor or asking their oncologist, please test my daughter or please test my sister. So we're not actually volunteering to test all the family members unless they actually kind of step forward and say, my family member has BRCA positive or something else. I'd like this test done as well. And then the question is, who's going to be responsible for not only, you know, getting that test, but then what are we going to do about the results? So you are asking for a lot, but we're with the more information we have, I think the better we're going to get at dealing with the results.
Should the genetic testing be begin before the cancer diagnosis, maybe with a primary care provider? I know we've talked about their responsibility, but this comes from one of our participants here tonight.
Yeah, I mean, I think if the patient has a concern, I mean, the primary provider is not going to voluntarily say, let's talk about your family history, I'm thinking about ordering genetic testing if you've got a positive one. That's not primarily going to be on his mind. But I think when the patient actually comes and says, this is my concern, yeah, I'm here for my primary care, but my concern is I may have a positive family history, several family members with malignancy, and just starts volunteering that information. I mean, we're putting a little bit of the burden on the patient, let's say, but I think that's important. And I think the more we, as doctors, allow them to do that and have that information to be able to answer their questions, the better off everyone's going to be. And this test is going to be done more often. We're going to save more lives.
Back to insurance for just a moment. How do you recommend a patient, or what do you recommend a patient do if the insurance company denies the genetic testing when the data shows that the person that is a candidate for the test? Test costs a minimum of $2,800 minimum, and if the patient can't afford to pay for the test.
Appeal.
We have an appeal process.
Keep appealing. So usually, they're this way with us, and they're this way with the public. They put up lots of hurdles to pay, and then you just have to knock the hurdles down, and if you don't get it on the first try, you get it on the second.
Be persistent.
Yeah, our staff are awesome at that. We're very fortunate in radiation oncology, both in our Brunswick County office and the Wilmington main office. Our staff are just, you know, insurance companies say, well, we're not going to pay for that. Now, we're not going to pay for that test. We're not going to pay for that treatment. We're not going to pay for that more expensive form of radiation. And if we feel, and generally, we, you know, I'm very much a minimalist. I'm not going to order something if I don't feel it's going to impact somebody's care. But insurance companies don't know that, so they just put up the hurdles. And they assume that you're not going to fight. And therefore, you know, why shouldn't they throw up the hurdles? It doesn't cost them anything to say no. But in general, when you appeal, I would say 90+% of the time, we're effective at getting what we need for the patient. And in general, that's the case for patients. As long as they have the right baseline information and they are eligible for the test, they should just keep appealing. It's a pain in the butt, and it's a hassle, but it usually works.
The process is streamlined, as Pat said. they put up a hurdle, and you probably won't, you may not call, and then the insurance company will save money. But if you've got an effective staff, but at the most will happen is they'll give you a phone number and with an extension and say, call this number, speak to this, and the doctor will actually have a doctor-to-doctor conversation, and it usually gets taken care of. But it's an extra 10 minutes of time or more, from the doctor's day, and so they know that the doctor may not actually have time to make that call. So,
specifically here in North Carolina, we're one of 7 states where Medicaid does not cover genetic testing at all whatsoever. It doesn't matter your age of diagnosis, family history, there's no coverage. Medicare coverage is very good. So if a patient meets National Comprehensive Cancer Network guidelines, Dr. Webb referred to those, and there are copies. The pink is the hereditary breast and ovarian, and the purple is the colon and endometrial, the Lynch spectrum. Then they're covered at 100% with Medicare. If they meet criteria, there is no cost to the patient per NCCN guidelines. And most third-party insurance coverage in this state follows National Comprehensive Cancer guidelines pretty closely. And every company is different, and there are different genetic testing companies out there, and all of them have a threshold of different amounts before a phone call is made to choose whether or not the patient wants to move forward with testing. There's financial assistance out there. I mean, even this organization putting this event on has financial assistance if a patient truly needs it. And there are lots of different resources. But if a patient does not meet criteria for testing, National Comprehensive Cancer Network criteria for testing, then they probably aren't going to get tested, even if appeals are done. So if they do meet criteria, yes, an appeal is absolutely an option. But hopefully whichever office that you're going to as a patient, and every single healthcare provider in here really understands those guidelines and the thresholds, because that's what insurance companies follow.
And I guess, Greg, you can use the word frustrating when you hear that from the patients, right?
Mm-hmm.
They've been denied. Frustrating if you hear somebody come in and they meet the criteria, but they get that rejection from the insurance company. You can use the word frustrating when you just sit back and look, because you know how it's needed. And,
right. And I must say, I don't find that a problem. I've found that the companies have approved. I can't remember the last denial that we've had. The issue is some companies approve, but their pathway to the test is 8 weeks. And other companies have a 3-week pathway to the test. That's the issue. They'll approve, but the pathway to have the answer is different. But I've not been on the phone with people who've been denied. I think that's been fairly well worked out. I'm looking out at Casey. I can't think of a recent denial. So I think that's more of we have that on other things, CAT scans, MRIs, et cetera, but not so much the genetic testing.
I do run into the problem in Columbus County. There is a high Medicaid population there, and it is a little difficult it's very difficult to know if someone might need a test that we really just can't get, that they can't afford. And I've even had patients saying how much is it they're willing to pay for it, even though they know it won't get covered. And I think sometimes we're able to contact some of the companies and get those covered, but that's kind of a problem in the mindset of some of the doctors too. They may realize, well, there's an expensive test out there, your insurance won't cover it, so we're just not even going to even discuss it. And I think that's a mistake. At least they have to be counseled that there is such a test, and that they're appropriate for it. But there's a problem in many counties here in North Carolina with patients on Medicaid. That's something we still have to surmount.
Still have time for some more questions. Anybody has, in particular, one that they would like to go ahead and ask? We don't mind hearing from the audience right now for a moment, too. Everybody's got all the answers they need.
I've not read any data that way.
It's a fairly even distribution. HER2 positive cancer is about 25 to 30% of the cancers. There's a lot of focus on that particular cancer because of the targeted therapies, Herceptin and newer drugs that are coming out. And we're finding even more receptors that actually work with the HER2 receptor. That accounts for, most of what you hear about in the news is a lot about the HER2 positive cancers. That accounts for about 25 or 30%. And the triple negatives do tend to be pretty common, somewhat more so in the African American population as well. So we might see a little bit more of that in our area.
Are we seeing more thyroid cancer?
Yeah, we see a lot. Just in general, more global to the question, the thyroid cancer has been diagnosed a lot more often because we're looking for it more frequently. And a lot of primary care docs will feel a lymph node in the neck, which is a reasonable thing to do. And patients are getting ultrasounded more frequently in the neck. Fortunately, thyroid cancer is generally very curable, the most common. But thyroid's a common, the big four in the country are the big four here, which is lung, which everybody should know kills more people than breast, colon, and prostate together, and those are the other three. So those are the big four here as they are in the rest of the country. The most, where we deviate from parts of the country is that we have underserved patients that are either minorities or poor whites, and we have higher percentages of more advanced disease in those cancers. So more stage 3 and 4 lung, breast, etc., more high-risk prostate cancer for various reasons. Some genetic and some socioeconomic, but we have more of that than the average population. If you were to go to a major city, we see more of that here.
You see on the news, John Stossel, who is Fox News correspondent, just came out today. He has lung cancer. And he said, I think it was 1/5 of his lungs removed. He's not worried about the lung cancer in his posting. He says the customer service at the hospital is what he's concerned about. And of course, that's the area he writes in consumer affairs and things
one
like
thing
that.
One thing we're seeing a rise of is lung cancer in non-smokers. It used to be exclusively a smoking-related malignancy. Now we're up to 10 or more %. And we're finding, again, back to genetics, certain genetic mutations that are particular to non-smoking cancers. There's a gene called the EGFR gene, which is similar to the HER2 gene in breast cancers. I think a little bit more in Asian population, Asian female, non-smoker, that would be the most typical, but we're seeing it in others too. And then other mutations, something called an ALK gene mutation has been found in non-smoking lung cancers. So yes, don't smoke, but be aware that there is such an entity as non-smoking lung cancer, and it's becoming more prevalent, and we're finding it.
And is there any connection with the e-cigarettes when you're talking about any form of cancer? I know when I was growing up, you had plenty of tobacco here. That amount that's been grown has cut quite a bit. Smoking numbers are down quite a bit as well. But so many people, especially young people, are going to the e-cigarettes.
I think if e-cigarettes cause cancer, they're preventing more than they're causing. I think by having a nicotine substitute available to smokers, I think that's a great way to get them to help them stop smoking. I think it's going to prevent more cancers. There's no evidence that electronic cigarettes, which are really just pure nicotine, are going to have any carcinogenic effects in them. A cigarette has about 3,000 chemicals in it, hundreds of which are carcinogenic. The e-cigarette only has nicotine, so it's really just designed to help folks get off smoking. So I think it's going to prevent more cancers than cause, if it causes any at all.
Okay. Any questions?
Every community has a cancer registry. So if you go online and just Google cancer registry and put whatever zip code or community you're interested in, the hospitals feed into that cancer registry database so you can find specifics as far as what cancers are more prevalent in our area.
And they can call your office and give the right direction as far as getting information about everything we've discussed tonight.
Yeah.
They can lead you in the right direction.
Bob, I was going to comment on a couple things. One, just a basic definition. I mean, really we're gathered to talk about genetic and family risk. And the term close relative has a medical definition. And the medical definition is any first, second, or third degree relative. And as doctors, we typically ask about mom, dad, brothers, and sisters. But a first degree relative is a parent, a sibling, or a child. A second-degree relative would be a grandparent, grandchild. Third-degree relative is out to aunts, uncles, and first cousins. That is still technically a close relative. So that's, if you're going to take a pause on the family history, I doubt you're going to ask every single thing about it. We could be here talking about aneurysm screening. Now, I don't think the primary care is going to say, well, tell me every medical problem all your 3 degrees have, right? So it sounds easy to say we should be doing this more. But there are many diseases out here with different panels saying we should be asking about stroke risk, aneurysm risk, dementia risk, et cetera, and we just can't do all those things. But once you put a foot on cancer, the patient brings it up, then we have to understand when we say close relative, we're talking about 3 generations. Then I want to just put a word in about thyroid cancer, because that's a big part of my practice, is thyroidectomies as well. One of the big reasons we see a rise in thyroid cancer may not be because there's an actual increased incidence, because very few people die of thyroid cancer. The actual reason may be we're just discovering more nodules on imaging done for other reasons. It's one of the most common reasons I see a patient for a thyroid nodule to do a biopsy, is they've had imaging for some other reason. So for instance, I bought an ultrasound machine and I was calibrating it one day and I happened to scan my own thyroid and I found 15 nodules. I was like, well, turn the machine off. Wish I didn't do the study. I ended up having a biopsy, kept my thyroid. A third of men have thyroid nodules. Half of women have thyroid nodules. The thyroid's a nodular gland. Ask any woman about her own breast exam. It's nodular tissue. But the rise in thyroid cancer may not be a true increase, because many people will take thyroid cancer all the way to their deathbed and never even know it. It doesn't expand, doesn't grow that much, doesn't spread, doesn't take many lives. It fairly infrequently does. I've been here 17 years. I've had 2 patients die of thyroid cancer. And I'm seeing hundreds of thyroid patients a year. So it's not like the breast, ovarian, these sorts of things that we really need to be very far ahead of the game on.
Well, we have no other questions. Why don't we just sort of just wrap it up, let our panelists just conclude what they have tried to get accomplished, to let everybody know about the issues we've talked about tonight, and with a final comment. And how about you, Tammy?
I think it's just, both for the medical community, taking a good family cancer history, and for the patients too, knowing your family cancer history. So having that knowledge is power when going in to see your physician or seeing your patients, just treating them better, so.
Patrick?
I would say, I guess, piece of advice going in when patients go in to see doctor, if you have a relative who's been diagnosed with cancer, go in with your questions in hand so that you're well informed, whether it's genetic testing or anything else. Too many patients will come in, even with family members, and sit and wait, and kind of, we give the information that we have, but they then, of course, the next day or a week later, they have all their questions. So go in with your questions, genetic or otherwise, in hand.
Or you hear him going out of the room, why didn't you ask him that?
Right.
Stuff like that. You should have asked him that.
That's right.
Sarah?
One of the things I've started doing with my history taking also, and I've done this probably for years, when they tell me whoever died and you ask what they died from, and often that will reveal a cancer that they just hadn't thought about. So don't be afraid to ask. We have to ask.
Yeah?
Yeah, I mean, I think the science of what we're talking about here is wonderful. I think this is giving all of us in the medical field, as well as in the community, a lot of confidence about how we're treating cancer and how we're diagnosing it. This is a real testament to to have companies that have genetic testing like this available. I think it's giving us all a lot of confidence, and that we have even more to look forward to in the future, that things are going to get better as far as the treatments for these diseases, as far as earlier diagnosis and even complete prevention.
How about Heather?
You know, we've talked a lot tonight about breast cancer, which, you know, that's in the news, and we have an Angelina Jolie out there talking about BRCA mutations, and we touched a little bit on it, but Lynch, or hereditary non-polyposis colorectal cancer, it's a really big long name, is just as prevalent as carrying a BRCA mutation, and that is, there are 10 cancers in that spectrum. So colon, endometrial, gastric, and ovarian are the top 4, but pancreatic is in there, glioblastomas, sebaceous adenomas. I mean, the list goes on and on. So it's really important that we don't just focus on those breast patients, but we really are looking for those colon cancer patients, because there is, like I said, there are as many Lynch mutations out there as there are hereditary breast and ovarian cancer. And all of you have one of these little forms. Please fill it out, because we really need to know what you need for education moving forward. And that's what we'll focus on. So we talked a lot about the breast side. If colon really is something, that colon endometrial side that you want to focus on in the future, please fill that out so that we have that information, so that whatever we do moving forward really is relevant to what you need. And thank you. And honestly, I love the nurses and the medical assistants, because y'all catch things, and it matters, and what you hear matters. So thank you for everything you do.
Dr. Bibb.
There's a great shortage in this country of organs for transplant. And so there's a phrase out there called start the conversation, right? What do you want to do if you had a sudden event where you're going to die? What do you want to do with your organs? And I think we could steal that phrase for this problem, start the conversation. I think this has legs for you in the family as you have a conversation about medical issues. Well, what is our medical history? You should start the conversation. You should know your family history from the patient side. We can start the conversation. We may not get this all completed in one 5-minute short of breath doctor visit, but you start the conversation and you lay a little bit down step by step. And I think this is part of starting the conversation.
Very good. Thank you all for joining us again tonight. Raised some good questions, got some fantastic answers. Hopefully all of you have got your questions answered, and the folks that are watching us streaming this over to Whiteville and also to Supply, hopefully your questions are answered as well. We thank you for coming out tonight, taking the time to join us. Hope you all will be back with us in about a year from now. We'll do this again for our 7th forum. So thanks very much, and thank you all for coming tonight.